Thank you, Ed. A terrific presentation. And I want to thank everybody that made possible for me to be here, speaking to an audience that is certainly different than the audience I'm used to speak to, but I'm really excited to learn the perspectives of interventional radiologists on this. And these are my conflicts. And I will speak for about 15 minutes about the functional anatomy of the viruses, and I think this is important to make things simple. The physiological consequences of TIPS as compared to endovascular obliteration, and the use in clinical scenarios, and what are the treatment choices in bleeding from gastro-fundal viruses from the perspective of a gastroenterologist or hepatologist. And I will explain, once again, you have heard about the ASLD guidelines that I was honored to co-chair with Ed Lee. So this is the functional anatomy of the viruses, and from the gastroenterology point of view, we know that when we see gastro-fundal viruses, the vascular anatomy is completely different from esophageal or gastroesophageal viruses type 2, because they have these, they normally come from collaterals that come from the splenic vein, but also from short splenic veins, and these end up in portosystemic shunts, mainly in the renal vein, in the left renal vein. So anatomy is different, so how this impacts what we do with these viruses. And I wanted to put this video that is from, sorry, I don't know how to start this video. Do you know how to start the video? Oh, here, yeah. So this is, from a long time ago, you see 2007, this is a TIPS I did in Spain when I was working there. You see, it was still an uncovered stent. We didn't have too much money. And you see there is a Linton balloon inflated in the stomach. And despite that, the TIPS was opened, the Linton balloon was inflated, and despite that, when you injected contrast in the splenic vein, most of the contrast will go through the gastrorenal shunt and obviously through the viruses. And this is, before doing this case, I think everybody in my unit, that was a unit devoted to portal hypertension, thought that RTO didn't make sense. It was done mainly in Japan, and they didn't understand the hemodynamics, because obviously if you put up a plug or if you do something in the outflow of these viruses, the pressure in the portal vein will increase, so portal pressure will get worse. But after doing this case, we clearly we clearly understood, because the case was completed by trying to put some coils in this big collateral, but what we saw is that we occluded this collateral, and the nidus of the viruses was fed by several other collaterals, many of them coming directly from the spleen, so could not be embolized. So we did not achieve hemostasis in that case. So this is when we start thinking that we need something different, and we start thinking about RTO. So these gastrorenal shunts are frequently larger than 10 millimeters, which is the diameter of a TIPS, and frequently, the viruses nidus has several feeders, so it's difficult to embolize from an anterograde perspective. So, physiological effects of TIPS, it decreases portal pressure, but increases portal systemic shunt and increases the risk of worsening liver function, and especially the most devastating complication of cirrhosis, which I think is hepatic encephalopathy. Having the threat of hepatic encephalopathy in your daily life, if you need to drive, if you need to whatever, it's really terrible for your quality of life. And it induces a hyperdynamic state. So my impression is that TIPS was initially thought as a short-term treatment, as a bridge to something. But when you have a portal systemic shunt in your liver working for 4, 5, 6 years, especially in patients, for example, that stop drinking, they have like a second disease. RTO, very different, and I acknowledge we didn't understand it at the beginning. Now I think I understand it very well. redirects the flow to the portal vein. So this might worsen portal hypertension and might worsen esophageal varices and ascites, that these complications might be controlled, and if they are not controlled, you can complete it with small tips, and might improve liver function, especially if you are not beyond that no return point, and this is what that study shows. Its MELD is very high, probably. It has very little capacity to improve liver function, and certainly might improve hepatic encephalopathy, because portal systemic shunt, these large portal systemic shunts are a huge risk factor for hepatic encephalopathy. And the anatomical requirements is that the shunt can be accessed retrogradely, and there is a patent portal vein, or enough, when the portal vein is not patent, but sometimes there are enough portal-portal collaterals that can accommodate the redirected flow to the liver, it can be done. And this is probably for the gastroenterologist and the hepatologist, this is probably enough. And I think one of the barriers for the gastroenterologist and hepatologist understanding RTO and when it was indicated was that we were presented with classifications of 6 types or 8 types of gastrorenal shunts that we thought that we will never able to understand to indicate an RTO. I think this is enough to go to your interventional radiologist to discuss the potential of RTO. And this is the approach, how we use this in clinical practice. When we have a variceal hemorrhage, we normally try to manage the bleeding with vasoactive medication. If there is an expert endoscopy, they might try to treat these varices. But then, if there is uncontrolled bleeding, then we have to go to endovascular treatments. But the bleeding is controlled. We have the question whether we should go to endovascular treatments, TIPS or RTO, or whether we should continue with endoscopic therapy. So this is the first question I want to pose, which is, should we pursue endovascular treatment if bleeding is controlled, or should we continue with cyanoacrylate injection? And the evidence clearly supports to go to endovascular therapy. There is one randomized trial of TIPS versus cyanoacrylate, a little bit old, but was less rebleeding with TIPS, more encephalopathy with TIPS, no difference in survival. BRTO versus cyanoacrylate, they are small trials, but this was published quite recently, less rebleeding with BRTO, no difference in other complications, and no difference in survival. But there is this very recent study, and I still have there, that was presented in AASLD 2023, but is now published in clinical gastroenterology and hepatology. That is very interesting because they randomize the patients to endoscopic therapy or to RTO or TIPS, depending on the feasibility and the interventional radiology preference. If the patient was only candidate for RTO, or only candidates for TIPS, and a candidate for both according to the radiologist's preference. There was clearly less rebleeding with the endovascular therapy as compared to repeated cyanoacrylate injection, and survival was not significantly different, but was substantially better. And this happened also in the BRTO versus cyanoacrylate trial. And the pattern of complications was the pattern of complications that you will expect from these therapies. Patients with TIPS had more hepatic encephalopathy. Patients with RTO had more ascites, more pleural effusion, and more secondary development of esophageal varices. So my answer today in 2025 is that evidence supports endovascular therapy, even though there is no clear survival benefit as compared with endoscopic therapy. But the fact that you have less rebleeding is an endpoint relevant enough to choose between two therapies. Cyanoacrylate, TIPS, and RTO have very different adverse effect profiles, so you can think about that when you offer this treatment to the patients. And it's true that cyanoacrylate injection has evolved, and there is recent refinements in endohepatology with endo-US, coil-assisted glue injection, and these have not been tested against endovascular therapy in randomized trials. So the second question, if both TIPS and RTO are feasible from a vascular anatomy point of view, which one should we choose? And the use of TIPS will be favored if there is very good liver function, there are large esophageal varices that might get worse with RTO, and there is significant ascites in a patient with refractory ascites. It's difficult to do only RTO. It has to be at least completed with small TIPS. And when there is portal vein thrombosis, because you can rescue the portal vein thrombosis with the TIPS, and favors RTO in patients that had previous hepatic encephalopathy, that had poor liver function, and have the local experience. And I don't think there is a MELD threshold in which RTO should not be used. We know that the higher the MELD, the lower the chances to improve that. But obviously, the intention of RTO, the primary intention is to control the rebleeding from gastric varices. And obviously, if the patient has a very high MELD, the patient will die, otherwise does not get a liver transplant or a treatment of the underlying disease, for example, abstinence from alcohol-associated hepatitis. The follow-up after doing RTO, we do a CT to confirm that there is complete obliteration, and we do follow-up endoscopy in 1 to 2 months to evaluate the development of worsening of esophageal varices. And if we see varices, we follow the regular treatments. So this is my summary. TIPS and RTO induce markedly different physiological changes in the spinal circulation, which explains the different adverse effect profiles. In patients with hemorrhage from gastro-fundal varices, TIPS and RTO are better at preventing rebleeding than endoscopic therapies. This is data from randomized trials. And choice between TIPS and RTO are determined by the vascular anatomy and patient's profile of previous complications. Thank you very much.